Hello, welcome to Cardio Flash College, a place to learn cardiology with flash animations. Today we continue with our weekly section Flash Code, a place to explore the world of acute coronary syndromes and primary angioplasties. Let's begin. This week we have a man of 53 years of age, smoker with arterial hypertension and backgrounds of ischemic heart disease, clinically displayed as a myocardial infarction on 2011 in the context of 3 blood vessels coronary disease that was completely and percutaneously revascularized with drug-active stents. He arrives at our unit with the diagnosis of STEMI of approximately 4 hours of evolution. His clinical situation is stable, but chest pain persists. This is the electrocardiogram of our patient. As you can see, it is evident the existence of changes on the ventricular repolarization. These alterations express as elevations or descents of the ST segment in some leads, and they suggest an acute myocardial lesion. Could you identify these disturbances? That's it! In this electrocardiogram, we have an elevation of the ST segment on inferior leads 2, 3, and ABF. It is relevant to point out that the elevation of the ST on 3 is higher than on 2, and there are no changes of the ST segment on right precordial leads. This is why we can expect the right coronary artery to be responsible of this infarct, not the circumflex. In any way, it is evident that the patient has an inferior STEMI. But what clinical relevance does this have? Very simple. ST segment elevation myocardial infarction is the regular clinical manifestation of a complete blockage of a coronary artery and constitutes a cardiological emergency where every second counts. In this way, our main objective is to open the artery as soon as possible, whether it is using fibrinolysis or primary angioplasty. In this case, primary angioplasty was performed. As you can see, the branches of the left coronary tree are open. It is angiographically lesion-free, nor any restenosis exist on previously implanted stents in anterior descending and in circumflex arteries. Let's take a look at the right coronary artery. As you can see, there is a complete occlusion in one of its distal bifurcation branches, specifically in the posterolateral tree. In this projection, we can also see that the occlusion occurred inside the stent. It is more possible, with these circumstances, that the acute coronary syndrome is due to the destabilization of the neoatherosclerosis plaque. Now we know where the obstruction is and we only need to treat it. First thing to do is to pass an angioplasty guide wire through the closure. Sometimes, as in this case, passing the guide wire partially opens the artery and allows us to see part of the distal bed. The next step was to implant a stent on the blockage zone. This props the artery and returns blood flow. And this is the final result. As you can see, we have recovered the blood flow of the artery after implanting the stent, obtaining a good angiographic outcome and without pre-procedure complications. In this way, with the artery open, the ST alterations are progressively improving and pain disappears, being this emergency resolved, and with it, our chapter. It has been all for today in Cardio Flash College. We hope you liked the video. If so, subscribe to the channel and leave a like. We'll see you in the next class. And remember, don't come late. Bye!